Hey everybody, I am now arguing with Ivor Twitter. I want to jump out the window of the 5th floor that I'm currently on, but I have to actually record this podcast intro first. So this is episode 1 or 2 of the podcast. It'll be labeled on your podcast app, whichever one we decide to make it. This podcast is with Cyrus Khambatta, myself, Avi Bitterman, and Ethan Weiss. The topic for discussion is whether the insulin resistance, quote unquote, of the ketogenic diet is pathogenic or not. Is there anything harmful to having transient insulin resistance to the ketogenic diet? To prepare for this podcast, Cyrus uploaded a document with important questions that he has about the ketogenic diet and especially its relationship with insulin resistance. And Cyrus and I went back and forth about different aspects of this document, and we now have everybody together to talk about it. Cyrus is the co-founder of Mastering Diabetes. As I understand, it is both a program and, for him, a clinical practice for helping people with diabetes to manage their blood glucose. And his approach is based on a high carbohydrate, low fat diet that helps to increase insulin sensitivity and reduce insulin needs and medication needs, and in many cases reverse type 2 diabetes. He's been very successful, and I know people who have the utmost respect for the way that he has organized his program and his practice. Apparently it's incredibly effective, and there have been many patients who have gotten extraordinary results from the approach that he takes. Avi Bitterman is a PGY1, means postgraduate year 1 out of medical school. He might be a year 2. He works on clinical trials, he does research, and he is going to go into dermatology. So I think he took a fellowship year off after medical school and has used that time to do research, and he will then be going into dermatology. If I'm wrong about that, Avi, please correct me, and we will get that corrected for the next episode. Avi will be my co-host on as many of these podcasts as possible. There's some people who may want to participate who might want to only discuss or debate with one or the other of us, but as many podcasts as possible, I would like to have Avi on because he's such an incredibly intelligent individual and very dedicated to the truth and to logical and systematic investigation of various important arguments in the health and nutrition space. He is currently in New York, I believe, and he is affiliated with Mount Sinai. The next one up is Ethan Weiss, professor of cardiology at the University of California, San Francisco. He has been involved in research on metabolism and earlier than that, I believe, thrombosis and clotting for several decades now. He's a medical doctor and he sees patients. He prescribes low carbohydrate diets to his patients, and he runs a company called Keto or Keto, depending upon how it is supposed to be pronounced. I think there's no supposed to be. I think it's different depending upon who you talk to. But he is the co-founder of that company, and that company sells devices that people basically breath analyzers that measure acetone. People can blow into it and track their ketone levels and use their smartphones to dynamically track their diet behavior and integrate what they're doing with other people in the keto community. So there's competitions, apparently, message boards and all these kinds of things about ketone levels and weight loss in that community. I've only recently just gotten to know Cyrus. He is a good friend of Danielle Bellardo, and Danielle has had him on her podcast. I know him through her, so she introduced us to have this discussion because it has been the case in the past that Cyrus has been sometimes more skeptical of ketogenic diets for the use of treating diabetes. And yet Danielle is saying that might be an option for some people in not just diabetes, but for weight loss and all sorts of things, especially if it's correctly formulated and it's not a diet heavy in animal product. I've just recently actually met Avi as well. Avi, he was the guy who, during the last day of preparation, helped James Wilkes to prepare in his debate for Chris Kresser. I asked around who did that, who helped, because I felt that was a very impressive debate performance by James. Being a layman, it wasn't perfect, and there's many problems, but it was a very impressive performance. And so I wanted to know who was behind that, or one of the people behind that, because apparently James has a substantial team. And apparently that was Avi, so I found out and we got in touch, and then I was very impressed on what he does on Discord and with debates. And we are on a very similar wavelength. We are on a similar wavelength with slightly different or substantially different skill sets, and I think we complement each other quite nicely. So that's why I proposed to him to be my host on this podcast. Yeah, and then the last person is myself. So I am a medical student, an MD PhD student, currently finishing my PhD in biochemistry. I study ketogenic diets and also different drugs that affect the receptor for beta hydroxybutyrate, which is called GPR109A, and I look at cancer. And so I am in Texas, and I should be done with the PhD pretty soon, and it should be done with medical school. So hopefully all of that will be done within the next 3.5 years. Long-standing interest in nutrition, people who have been following me for some time will know about that. And then additional information about each of us will be able to be found in the notes for this podcast, or at least perhaps the podcast description. This was a great conversation. We went in with me asking Cyrus if we could record this. Cyrus very politely declined. He said he thought it would be better if we could hash out our differences over voice prior to recording for a podcast. And so I was like, that's fine. We'll do that, and we will then do the podcast. And so, yeah, we came to that agreement. However, as it turned out, the podcast went really well, or I guess it wasn't a podcast, but now it's becoming a podcast, but it went really well. We had a very constructive discussion and asked Cyrus at the end if he wanted to just put this out as a podcast instead. And I think that's better because you can see the thought process through which we reach some conclusions and don't reach other conclusions in the course of this discussion. So this is going to be our discussion. We touch on several different issues about insulin resistance. Is it harmful? Are the diagnostic criteria for reversal of diabetes correct? How do ketogenic diets affect blood glucose levels? What are the mechanisms through which they do so? What are the things we see with our patients? We even talk a little bit about the carnivore diet and different clinical trial designs and how they do or do not get at the question of how to treat diabetes. Without any further ado, I hope you enjoy this podcast. I enjoyed it a lot, and I'm so proud of what we achieved here. Give it up for Cyrus, Avi, and Ethan.
From what I understand, insulin resistance is a blanket term that encompasses three things. Number one, glucose intolerance. Number two, hyperinsulinemia, either in the fasting and or in the postprandial state. And then number three, hyperglycemia in the fasting and or postprandial state. So if you combine glucose intolerance with hyperinsulinemia with hyperglycemia, then you add the three of those things together and you get this thing referred to as insulin resistance.
And by glucose intolerance, what do we specifically mean by that?
Glucose intolerance refers to eating, like if you were to perform an oral glucose tolerance test. So you go to the laboratory, you take a 75-gram bolus of glucose in water, and you monitor your blood glucose and insulin values over the course of the next 2 hours. If your blood glucose, according to the ADA, if your blood glucose goes above 200 at any point in that, then technically speaking, you have type 2 diabetes. But if your blood glucose, I believe the number is 160. If your blood glucose goes over 160, then that's classified as being insulin resistant, or in this context, glucose intolerant.
Okay, and so what you want to know is there any data if someone takes a glucose tolerance test, goes over 160, is classified as glucose intolerant, but they're walking around with normal glucose levels, normal insulin levels?
Bingo.
Are they going to have any problems? That's the question.
Yeah, are they going to have any problems in the long term? And the reason why this is actually such an important question, at least in my mind, is because in the low carbohydrate community, whether you're following a paleo diet or a ketogenic diet or even an Atkins protocol, there's a lot of people who, number one, they eat one of these diets and they lose a dramatic amount of weight, which is a good thing. They normalize their blood glucose values, meaning that their blood glucose used to be elevated, fasting and postprandial. and then their glucose value comes down below 100 in the fasting state, and they can effectively flatline their blood glucose all day long. I mean, there are so many people that eat a very low carbohydrate diet, and their blood glucose values literally fluctuate between 80 and 90 or 80 and 95 all day long. It's very impressive, to be perfectly honest.
And these would be glucose intolerant people that are just maintaining normal glucose levels.
Exactly. Highly glucose intolerant people.
Okay, so here's a distinction I would like to introduce to this discussion, because I think there's two kinds of people who get their blood glucose down, and then with a low carb diet, and then whenever they go into a high carb diet, there's two separate kinds of responses potentially. So I think there's a kind of person who can get their blood glucose down, say, between 70 or 90 on a low carb diet, and it's like that way. It's that way all the time. If they go on a higher carb diet, then maybe for 2 or 3 days, their blood glucose will be much higher, maybe even pre-diabetic or diabetic. But then after 2 or 3 days, it'll normalize again as their metabolic machinery for metabolizing glucose goes online. And then they're able to use glucose appropriately, and then they start to not be hyperglycemic anymore. And then there might be, and I actually don't think this person exists, or I suspect this person does not exist. There might be a kind of person who is euglycemic, say between 70 and 90, then it goes on a high carb diet, their glucose goes up, and then it stays up, say in the diabetic range. I don't think that kind of person actually exists. I think that if you're getting your blood glucose down like really low, like between 70 and 90, that means you're metabolically healthy. I think that people who are still diabetic and are restricting carbohydrate they're not going to be in the 70 to 90 range. That's my suspicion, especially based on looking at the Verta data and all sorts of other things. Just because I think you really do need to. My suspicion is that you really need to become metabolically healthy to start getting your blood glucose down that low. But somebody can chime in who has more experience. Yeah. The question is whether that kind of person even exists. Somebody who can get euglycemic, and then suddenly, if you give them the carbohydrate again, assuming they don't gain weight, is there a kind of person who actually becomes diabetic again spontaneously, even after being on a higher carbohydrate diet for several days? That's like a question. Yeah. So there's this idea that we're just controlling blood glucose with a low carbohydrate diet. We're getting people down to like between 70 and 90 milligrams per deciliter fasting, and then they're just staying at that level all the time. But there's this idea that if you put them on a higher carbohydrate diet, even after a week, they would be diabetic again. And I'm saying I don't know if those kinds of people actually exist. I think if you're getting down to those low levels of blood glucose, those normal levels of blood glucose, maybe after a couple of days on a low carbohydrate diet, you might be a little bit more, you might have a higher glycemia than normal, but you're not going to become diabetic again, especially after 3 or 4 days when you get used to it again, your body gets used to it again. So I'm questioning this idea whether you can completely control diabetes and get totally normal in terms of your blood glucose again, and then as soon as you take carbohydrate, you're suddenly a diabetic again. My belief is that the kinds of people who are controlling their blood glucose with a low carbohydrate diet but are still diabetic still have substantially elevated, even fasting blood glucose, and they don't go down to the normal levels. But somebody would have to, who has experience with this, would have to comment on that.
Want to make things more complicated, but I would be really careful to kind of define at least 3 broad categories of physiology. So people with normal, and I heard you guys talking a little bit about insulin sensitivity before, but just broadly speaking, people who are insulin sensitive, people with type 2 diabetes who have preserved beta cell function, and people with type 2 diabetes without. And I think they're all going to behave very differently. I think a person with ostensibly normal insulin sensitivity without diabetes who goes on a low carb diet will have, very good, very minimal excursions of glucose over the course of 24 hours, as long as they're on that diet. There is a phenomenon that's been described that people with normal insulin sensitivity on a low carb diet for some period of time will then become glucose intolerant on a glucose tolerance test if you were to do one. And that has been described for a long time. And I think the assumption is, I don't know how much this has actually been tested, but the assumption is that because the insulin requirements go down so low that the beta cells basically stop making insulin, and so that you have this temporary glucose intolerance, but you can overcome that with, carbohydrate loading for a couple of days. But for people with frank type 2 diabetes, either with or without preserved beta cell function, I'd be very surprised if somebody without beta cell mass would be able to, go back to eating carbohydrates again and tolerate that very well. I'd also be surprised if somebody even with preserved beta cell mass would be able to tolerate carbohydrates long term again. That's where I've sort of fallen into this disagreement with the Virta people over their definition of reversal, and I hate the word, and I've told them like 150 times I think it's a terrible word, but I also think, and I think mainly it's because it's a distraction. So I'm not exactly sure if that's what you guys were getting at, but
I would agree with you in that sort of Virta is using the term reversal in a little bit too of like a sort of over aggressively using that.
They're not actually. They're just to be fair to them, they're
Sure.
using a term. They would love to call it remission, and this is where the ADAs completely fuck things up, because there are these terms that don't make any sense at all. So in the ADA's mind, remission is more robust of a result than reversal. Reversal is like stage one. To me, reversal sound, the connotation of that word, the implication is it's gone.
Yeah, that should be like stage 4.
Remission to me sounds like, all right, well, you don't have any clinical signs or symptoms of it right now, but it's latent. And if you were to go back and like reintroduce whatever it is that was driving the pathology in the first place, you'd have it again. And so, but that's not the way the ADA defined the terms. And so Virta was, in fairness to them, they were responding to these ADA definitions that are absurd. But the term is terrible. I mean, reversal is a terrible word.
For sure. Okay. So going back to what you were saying here earlier about the ability of an individual to secrete insulin, that's a huge variable that we have to talk about if we're going to refer to somebody who's eating a low carbohydrate diet and then all of a sudden just begins eating a high carbohydrate diet, right? So if somebody's eating a low carbohydrate diet, do we all agree, and we don't necessarily have to, but do we agree that eating a high fat diet increases glucose intolerance? Is that safe to say?
Temporarily.
Okay, so define what you mean by temporarily.
Yeah, once you reintroduce carbohydrates again to the diet for say 3 or 4 days, you'll regain whatever was lost in terms of glucose tolerance within those 3 to 4 days after reintroducing carbohydrate.
Okay, so is there data that actually shows that it only takes like 3 or 4 days to regain the glucose tolerance that was lost by eating the high fat diet in the first place? Or is that just something that comes from like clinical experience and or like empirical experience? Because if it is, that's totally fine.
I think it's probably mostly that. I haven't looked. There may be some studies, but I know like Peter talks about it a lot, that if he has patients who are on low carb diet and needs to or wants to do a glucose tolerance test, that he has them pre-load carbohydrates for a couple of days.
Sure.
I've seen a randomized controlled trial. I've seen some graphs that are coming to mind right now. I'd have to find that study again, but I've seen data that's been published. And I can try to find that.
I mean, anecdotally, when I've worn a CGM and I've been like strictly low carb, if I either intentionally or unintentionally have a big carbohydrate load, it's like insane what the response is.
If you eat a low carbohydrate diet and then you have one meal that's a high carbohydrate diet or a high carbohydrate meal, then what do you see? Yeah,
I'll actually send you guys, because we did this for a donor event at UCSF. I did it with one of the diabetologists, and he ate a normal, regular. I ate a low carb diet, and we both wore CGMs, and we ate like brownies and like did these tests to like see what would happen. And I think we even did like drank sugar sweetened iced tea at the event, and you could see that my excursion was, the peak was higher, the area under the curve was bigger. I mean, it was definitely a much greater response to the same glucose load.
And this was known before the ketogenic diet literature came out. As in the fasting literature, there was something called starvation diabetes. So people who would fast for extended periods of time, they would see these exacerbated glucose excursions as soon as they broke the fast with a carbohydrate meal. So they called it starvation diabetes.
Right.
Yeah.
Valid. Okay.
And how long? And so, how is there data on how long it takes to reverse this glucose intolerance?
Yeah, that's exactly my question. That's a great question.
I could have to look. I'm not at a computer, but I would guess it's a few days.
Yeah, I'm not aware of any data off the top of my head.
I mean, the beta cell mass is pretty plastic. I mean, I think in mammals, obviously there are other animals like, the python is the best example. I think the pancreas of a python, when it eats a meal once a year or whatever it does, it like increases by 600% or something. But pregnant women have a gigantic increase in beta cell mass during pregnancy. So I think there is quite a bit of plasticity in a normal adult human pancreas.
And this is in non-diabetic individuals or in?
Yeah. In non-diabetic people.
Correct. Okay.
I mean, we see it in animal models too, right? I mean, if you can make an animal insulin sensitive through whatever mechanism, either genetically or through a drug or through a diet, you can see this temporary glucose intolerance, which is really basically a function of the way I describe it, like colloquially, is that the beta cells kind of have got sort of rested. So they're just not making insulin because they don't need it, because your circulating insulin levels are basically undetectable.
In the low carbohydrate setting. Yeah, right.
Very low.
Okay, so that makes sense. So basically, if you don't need the insulin, you're not taking in the carbohydrates. There's not a whole lot of function for the beta cells to be doing,
That's
and
right.
so you expect them to shrink. Okay, that makes sense.
Yes, it's a very highly energy intensive process to make insulin. So they're not just going to churn it out. So that's my like very simple understanding, and you can go back and there are papers describing this kind of stuff from 100 years ago.
The glycolytic machinery also gets downregulated as well. That's been shown, and that's especially in like the performance, like sports performance literature. If people go on low carbohydrate diets and they try to take glucose like right before a race, they can't use it as well, so they'll also load for several days in order to build up the glycolytic machinery. And it's been shown that there's phosphorylations on PDH that get altered and other enzymes. There's also down on the utilization end, there's changes as well.
That doesn't describe it. In fact, I think Jeff Volek showed that the beta oxidative capacity of carbohydrate or fat adapted athletes is increased by like 2.5 or 3-fold.
Yeah.
So there are all kinds of longer term impacts on metabolism that we understand, and many we don't probably too.
So then the question would be, so if someone decides to live in this state, so they're going to put themselves in a glucose intolerant state, but they're not going to be in an insulin resistant state. So they're not going to have hyperinsulinemia. They're not going to have hyperglycemia. They're going to control their glucose levels between like 80 and 100. They're flatlining it. But if you hypothetically would give them a GTT, that you would see them spike over 160 easily. Is living in this state where you're controlling the glucose, but you are technically glucose intolerant, does that have any negative health consequences or outcomes?
Exactly right. That is a great question. So personally, I'm not privy to any research that actually does ask this direct question and or show this. I don't know if you know of any data, Dr. Ethan. Have you seen this in the research itself?
I mean, the whole thing seems a little hypothetical to me, because I guess what this gets at is like, is it dangerous to cycle? I don't know, because people who are committed to staying low carb, that they're, unless they accidentally ingest a bunch of carbohydrates, they're not gonna. This is sort of a hypothetical problem.
So the reason why this has actually become to my attention over the last couple of years is because, full disclosure, we run a company called Mastering Diabetes. And Mastering Diabetes, we basically teach people how to transition to a plant-based diet, living with any form of diabetes. And, I've done this myself. I've been living with type 1 diabetes for 18 years. My co-founder, Robbie, he's done it himself. And what we've noticed empirically is that our insulin sensitivity has gone up inordinately by eating a higher carbohydrate, lower fat, lower protein, plant-based diet. So what we do is we educate people how to get there, to go from either a low carbohydrate diet or like in a standard American diet to a higher carbohydrate plant-based diet. Now, empirically, what people anecdotally, what people tell us all the time is they say, hey, we've been doing the low carbohydrate thing. I've been eating the low carbohydrate diet, doing my best to maintain something like 75 grams, 100 grams, maybe 125 grams at maximum of carbohydrate per day. Or some people are even eating ketogenic diet where they're eating 30 grams, 40 grams maximum per day. And they end up developing a whole bunch of ancillary side effects that come along for the ride. And then when they start to transition to a more plant-focused diet, the way that we describe, they say, oh my gosh, for the first time in a long time, I'm starting to get resolution of these other symptoms that I thought were just inevitable consequences of living with diabetes. And these symptoms include, the infamous brain fog. I don't like that term at all, but, inability to think clearly, we'll put it that way. Number 2, quite low energy, to the point where some people are even can't go outside. They're sort of stuck to being inside because they can't muster up the energy to get off the couch and move around. And then we also see people with impaired digestion who come through and they're sort of oh, I've been bloating. I have a lot of gas and a lot of constipation. And this is really challenging. And it impedes their quality of life. And then when they start to adopt a plant-focused diet, in more cases than not, people seem to see a lot of resolution of those other symptoms along with improved glycemia, reduced insulin requirements, and most often reduced body weight as well. So that's where this question originated from, is like, am I literally inventing these symptoms? Am I just trying to ascribe all of these other side effects to a low carbohydrate diet, or is that a real thing?
I don't know.
So I guess I could say a few things. First off, anecdotally, I know a lot of people do really well on a low carbohydrate diet. I think Ethan does pretty well. I don't want to speak for him, but as I understand, like Ethan, you still are on a low carbohydrate diet and you like it, right? But
2 years, and yes, and I do a very unconventional keto diet, very, very low saturated fat, mostly plants and fish.
Whereas for me, if I go on a low carb diet, or a ketogenic diet, I've done low carb for a really long time, but I'm not anymore, but I did for a very long time. And I did a few cycles of a ketogenic diet. I think I've done a total of about 6 months total. And each time, by the time I hit like several months in, I lose a lot of motivation and I lose a lot of energy. And I don't necessarily feel brain fog, but I feel like lazy. And that's something that's happened to me both times. I don't know what that's from. Maybe there's some individual variation. I mean, there's another caveat, which is it's not just the carbohydrate content that's different between these diets, right? Like there's also fatty acids are different, vitamins and minerals are different. You're getting different levels of phytonutrients. So all these other things that are involved in changing your dietary pattern from, say, a plant-based diet, from a low carbohydrate animal-based diet to a plant-based diet, especially the plant-based diet that you recommend people. A lot of things change. So it could be that there's something to being glucose intolerant without actually having hyperglycemic excursions.
I mean, physiology is physiology, right? You'll adapt to the physiology that you're exposed to. And so, I mean, again, there is a question I think that's interesting about whether people should cycle on and off of keto. That to me is a reasonably interesting question because of this phenomenon. But if you're like me, and other than like 2 days in the last 2 years, I've been pretty strictly low carb. I'm not sure, and I feel great. And actually, you hear as many people, and this speaks to like the nonsense of all of these like self-reported outcomes anecdotally, because there are a lot of people. I mean, people in the low carb community claim that they are like on some kind of stimulant because of the ketones, and they're have this focus and energy and da, 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 da. So I think that stuff all needs to be studied in a rigorous way. I don't think, to my knowledge, that's ever been looked at in a meaningful way. But again, I don't really care from an individual standpoint. If somebody feels better when they do a diet X, Y, or Z, that's great. I'm not going to like challenge them. It's really important how people feel.
Someone can go like for a really long time, with my understanding. Someone could go for a really long time. Their beta cells can be like really tiny and they're not producing any insulin. And they could just go for years, and then they introduce carbohydrates and they still would be able to get their beta cells up to have a high carbohydrate diet again within like a few weeks or something. Is that correct?
I don't know if that specific experiment has ever been done, but I think I would say the longest experience that we have with very low carbohydrate or ketogenic diets is in the pediatric epilepsy community. I think that those kids have been treated with some form of this diet for 100 years. I don't know of any one doing formal reintroduction studies. I know there are anecdotes out there, Kevin. I think we talked about the guy from the Charlie Foundation who basically went off of keto after like 3 or 4 years and his seizures never came back. And so there is some conversation about what the durability of the effect might have been on his brain, or whether he just after his seizures or what. But I don't know of any formal studies of reintroducing. I mean, the truth is that and I've talked to a few of these families, most of the kids who have a great response to keto with their epilepsy, they're extraordinarily sensitive to carbohydrates. I mean, these people are like on like 10 grams total carbohydrates a day, not like a typical 30 net or something. I mean, these kids are eating almost carnivore diets. They're eating nothing. And I think the moms and stuff that I've talked to say that their kids like will seize if they get if they fall below whatever 1 millimolar. I mean, it's all anecdote. So I don't know any studies. I don't know the longest duration of time that's been reported that somebody would reintroduce carbohydrates after being long-term low carb or keto. Steve Finney might know. I don't know.
There's some research here about like early onset and late onset side effects that come along with the ketogenic diet in these kids that are treated with a ketogenic diet for epilepsy. Paper published in 2004. 129 patients.
Their LDL cholesterol is insane. That has definitely been described. That was work I think that was done at Hopkins.
For sure. 129 patients treated with a ketogenic diet from 1995 to 2001. So it's basically a 6-year intervention. And then they looked for early onset and late onset complications. Early onset defined as the first 4 weeks, late onset. Okay, so kids basically treated, 129 patients treated for 6 years, in a paper to describe the early and late complications. And we see a lot of the complications that I was describing earlier, not necessarily a lot of them, but gastrointestinal discomfort seems to come up as a late complication for many of these patients. Hypertriglyceridemia, hypercholesterolemia, osteopenia, iron deficiency anemia. And so I guess one of my main questions is this only happening in children, or is the same type of, early onset or late onset complications likely to happen in adults as well who are following a ketogenic diet, with 30 grams net carbohydrate as well?
I don't think that diet is 30 grams net carb, unless I'm missing something. The Hopkins protocol for kids with epilepsy is extremely strict. Like it's much lower than a 30 gram net.
Because that he's right. Like that diet is very different from the diet that most people are using whenever they consume a ketogenic diet. It's also very protein restricted. A lot of times it's not even a solid food diet. They'll be drinking something called keto and that might underlie a lot of the gastrointestinal symptoms. So it's quite different from, say, like an Atkins diet, which is like 65% fat. It's more along the lines of like 87% or 91% fat, and then minimal protein, minimal carbohydrate. So a lot of those side effects that you're going to see in the classical ketogenic diet, the very strict ketogenic diet that they give the worst cases, is they're going to be probably significantly more severe, and there's probably going to be significantly more side effects than you would see with, say, an Atkins diet. So I'm not sure we can exactly generalize from those studies. I think there's some features and some aspects that we can, and I think that important hypotheses are suggested with respect to the Atkins diet because of what we do see with the classical ketogenic diet, but I don't think we can directly translate and say, okay, because the classical ketogenic diet has these side effects, therefore the Atkins diet is going to have these effects.
Okay, fair enough.
And the other big difference, the other humongous difference, and one of the things that worries me about that diet, and obviously they're using that diet for a totally different indication of what an average person who wants to lose weight would use it for, but the lack of fiber in that diet is really striking. Like that really worries me.
Ethan, what do you recommend the sort of like lower limit of fiber intake per day on a ketogenic diet?
That's a great question. I don't really even I don't believe in tracking macros, so I don't think about it. I just think about what I eat.
So I guess how would somebody know if they are like fiber deficient and at risk for many of these complications, or if they're eating an adequate number of grams of fiber per day?
Yeah. So the way that I frame it is I would eat unlimited quantities of non-starchy vegetables and don't even consider, like, there are people out there who believe that counts, that a carb is a carb and that a carbohydrate in a broccoli is the same as a carbohydrate in a cupcake, and that's nonsense. So I tell people don't track, because the likelihood of maintaining tracking for an average person is close to zero. So if you want to do something sustainable, don't start tracking. I mean, maybe if you're trying to solve a problem. So I just tell people eat unlimited amounts of non-starchy vegetables. Fruit is where things gets a little bit complicated. I think that's where things are, like, I wouldn't say unlimited, but I eat a lot of berries on a daily basis, and I've started eating other fruits as well, and stay happy and in ketosis and the whole thing. So and occasionally I'll take a supplements. I think, but I think I get a pretty decent amount of fiber in my regular diet. I mean, I'm eating a lot of plants, a lot.
Would you say that the average person who's eating an animal-based ketogenic diet is also getting an adequate number of grams of fiber per day?
No.
Yeah. Okay. So that's a potential confounding variable that could exacerbate their GI function and or many other aspects of their.
No doubt, and a lot of other things. I mean, there are all kinds of impacts, and I think we don't. I mean, there's going to be a lot more. Kevin and I both know about a study that's coming comparing low fat and low carb diets. And I think, make the thing that makes me the most uneasy about that study is just the lack of matching of any of the other, particularly the lack of matching of fiber. So that is a big concern. So the longer I'm doing this, the more impact I believe fiber has. And I think, there's a lot of evidence that whole fruit is obviously not the same thing as a refined carbohydrate or fruit
absolutely.
juice. So
absolutely. So going back to this
I don't tell people to restrict. I don't tell people to restrict vegetables at all.
Well, in Cyrus's defense, though, I think Ethan's approach to the ketogenic diet is very reasonable, and I think there are a lot of unreasonable people who like unreasonable approaches to the ketogenic diet. So,
but Ethan, you take a non-mainstream approach, which I think is commendable. It's fantastic, but
the problem here's the issue. Like, this is something that I've been thinking about a lot because I don't understand. Let me put it a different way. I'm trying to understand what drives a lot of the behavior in the low carb community. And I think what has happened is a function of several things. One is there's a group of people out there who feel like they were misled by, whoever it is, science, the government, something, told to eat, a certain way. And then somehow they discover this, magic potion that allows them to come off their insulin and manage their type 2 diabetes, lose 60 kilos, and they've had this revelation in their life. Some of those people then develop problems, one of them, the one that I care about, is they develop dyslipidemia, and those people then have to figure out a way to reconcile those two problems, right? So they've had this magic success with this diet. They feel better, look better, are healthier by every metric they can think of except the one. So I think the part of the reason that there's this LDL/statin denialism in the low carb community is because one approach to reconciling those two facts is just to dismiss the role of LDL cholesterol in coronary disease, which obviously I don't believe in. So I think that, it's a complicated, there's a lot there. You could spend a doctoral thesis work talking about the anthropology of the low carb community.
Valid point. So going back to this particular paper that we were just looking at here in epileptic children, it says here, all patients received the classic ketogenic diet with a lipid and non-lipid ratio of 4:1. So if we take a look at the table that Kevin posted, correct me if I'm wrong, but that's not like a hyper low carbohydrate diet, right?
Yeah, well, 90% fat and then 10% carbs plus protein. So all of the carbs plus all of the protein is 10% of the calories. So if say you're an adult, this is not an adult, but this helps us to understand what it would look like as an adult. If you're an adult, that would mean, say, a 2,000 calorie diet. That means 200 of those calories are carbohydrate plus protein put together. If that was 50-50, that would be 100 calories each. So 25 grams of carbs and 25 grams of protein, right? That's a really low amount. And then if you're going to increase the protein, then you're like 40 grams of protein and 10 grams of carbs. That's a really extreme diet that most adults are not consuming. So as Ethan points out, there's not, as far as I understand, there's not a lot of fiber in that diet as well. So it can actually be a liquid diet. There's something called keto cow. People will literally drink a liquid, basically meal replacement that's like 5% protein, no fiber. That's all sort of hyper processed foods, and a lot of kids will subsist to a substantial extent on that. So, yeah, it is a somewhat extreme 4:1. Classic 4:1 is quite extreme in terms of what we would normally think of as a popular ketogenic diet.
And the protein restriction, I think, is the other part of that, Kevin. That's very unconventional. And that's because they're so sensitive. Protein basically turns on gluconeogenesis. They're so sensitive to just even the slightest increases. So I think that's why they formulate the diet that way. But that is not the modern, what Steve Finney calls this modern, well-formulated ketogenic diet. So the modern diet has got protein. I think, it's roughly 20 to 25% protein, and 60 to 70% fat, and then the rest is probably 5% carbohydrate.
So you said 60 to 70% fat, 20 to 25% protein, and then the change is in carbohydrate.
Yeah, and in that case, I'm talking about net carbs, right? So that I don't count fibrous carbs.
I think part of the problem here is that, what free living human beings do when they're following a low carb ketogenic diet differs from the types of ketogenic diets that are studied in the literature. So I don't even know if this is an appropriate question to ask, but like, what do you think best represents a ketogenic diet that people, like free living human beings, are actually eating? Is it more of a 3-to-1 ratio?
Like if you look at Steve's book, it's relatively the macros I just described, although I think Steve is not really like a fan of, he's more of a total carb guy than a net carb guy. But I think that's what sort of modern, but your point is a good one. We have no idea what people are doing, especially if they're not tracking ketones, because you don't even know if people are actually doing it correctly. And my guess is that the majority of people who aren't being actively coached or not in a program are not doing it correctly.
Yeah. And even Cyrus pointed out that in the Virtus study, most people, the average ketone level was below 0.5 millimolar.
Yeah, it was 0.14 millimolar at 2 years.
That's fascinating biology that I think is a whole different conversation we can have another day. Because I think that reflects the sort of folly of using beta-hydroxybutyrate as a biomarker.
As a biomarker.
Yeah, I mean, the problem is the rate of ketogenesis is basically the sum or the difference between the rate of appearance of beta-hydroxybutyrate minus the rate of use. And as you become more keto adapted or more fat adapted, your rate of use goes up. And so I think that's part of the reason why you see these lower steady state levels. So I think if you did, carbon labeling and did stabilized stopes, you'd see people are robustly making ketones. They're just using them.
Just to add on to what Ethan was saying, though, as far as what's eating the world, I agree with all that, especially, and I agree with your points as well, Cyrus, that people aren't necessarily eating what's the ideal ketogenic diet in the literature. But as sort of a rough representation of what he was talking about for Stephen Finney, that would be in the table, that would be the modified Atkins diet, roughly speaking, something like 60 to 70%. I think that's what Ethan says, 60 to 70% fat calories and maybe like 35% carbohydrate plus protein altogether. 25 to 35%. But so that'd be closer to like 1-to-1 or 0.8-to-1 compared to 4-to-1. So it is substantially different.
And also very high, sort of relatively high saturated fat, which is something, again, that I disagree with in the sort of average, typical low carb keto diet, modern one, and the fiber is the other one. Yeah. But I think that the complicated nature of this business, I mean, this speaks to probably why people are glomming on to these diets like the carnivore diet. The carnivore diet, I think, is attractive to people. As much as it makes my head want to explode, it's attractive to people because it's easy to do. You don't have to really, it's not very complicated. You don't need a calculator, or you don't need a book, you don't need an app, you don't need anything. You need.
Yeah, that's a really good point.
Yeah.
Look, I'm not advocating it in any way. I just think it's important to understand where people are coming from. And the fact is, the reason we have this problem in our world today is obviously extraordinarily complicated, but the reason we haven't gotten out of it yet is because the solutions are not going to be easy, right? So I think we're clearly doing something, or probably a lot of things, wrong. Yeah. And one of the things we're doing wrong is making things overly complicated. And of course, I hate the carnivore diet. I think that it's idiotic. But I think the one thing that they've latched onto is that people respond to simplicity. They like to be able to do things that they understand and that they can do without making their lives overly complicated. I mean, it sounds dreadful to me, but
totally,
clearly there's something that people are like, it's working for them. And yeah.
So based off of what you're saying, then, if they're eating a carnivore diet, then they're going to be likely fiber deficient in the long term. So even though they might be getting short-term benefits from a carnivore approach, in the long term, they're likely to have a collection of side effects that come along for the ride.
Go on Reddit and
absolutely.
read the threads on the carnivore diet. There's like a belief out there that fiber is poison. Like, I think even people like Nina have said that fiber is like, you don't need it, that it's bad for you, and
fiber is toxic. Yeah, I can't do it.
So look, we're not going to solve that problem.
The difference in saturated fat is going to be a huge thing. I mean, I was looking at the keto cows, and I think they're maybe like they're soybean oil. That's where most of their lipids are coming from. It looks like it's going to be about 15% saturated fatty acids. The rest is going to be like 57% is going to be PUFAs. The rest are going to be MUFAs. So I think it's going to be higher with saturated fat on the carnivore diet for sure than if you're just chugging keto cow.
Mm-hmm.
Yeah. There are lots of problems. But look, I try super hard not to be like overly judgmental of how people choose to live their lives.
Simplicity always tends to win, and that part of the reason why the carnivore diet is so popular is because it's just a really simple approach. Really
It's simple
approach.
and sustainable in that way. Now, there are people like I actually had a conversation. I won't mention his name just to keep it confidential. I had a conversation there with one of like the prominent low carb physicians who's like very outspoken on Twitter, and he was telling me about a patient of his who was on a keto diet and his LDL cholesterol went to 700 and he developed xanthelasmas.
Holy.
And his calcium score went from 0 to like whatever, something positive over a short period of time. He did a carotid IMT, and that started growing plaque, and he was freaking out about it. And this is like one of these like hardcore low carb docs who was like recognizing this is a problem. So we're going to learn a lot hopefully in the next 5 years, and I'm hoping that we can learn it without a lot of people getting hurt in the process. But it is worrisome.
Okay, so taking it back to your original question, sorry. So I don't think we've been able to find any data to indicate that the state of just being glucose intolerant, hypothetically, even if you would hypothetically take carbohydrate in, you would skyrocket. But if you're practically in the real world keeping it flatlined at a reasonable level, just being glucose intolerant in and of itself, I'm not sure if we have any evidence that in and of itself is harmful. Is that right?
Yeah, exactly. I think from the scientific perspective, none of us have any data that we can point to that says, oh yeah, take a look at this study in which they monitored, glucose intolerant, normal glycemic, normal insulinemic people over the course of time. Here's what happened. The only data that I have is empirical data from having talked with many people who have a laundry list of side effects as a result of eating a low carbohydrate diet. But I'll be perfectly honest, those people are likely not normal glycemic and not normal insulinemic to begin with. So, they're not necessarily representative.
And there also might be differences that are orthogonal to just one being glucose intolerant and one not being glucose intolerant. There may be differences between why there are side effects between groups that are not boiling down to the glucose intolerant state in and of itself.
Valid.
A disproportionate number of people on a low carbohydrate diet are coming to you precisely because they're having a problem on the low carbohydrate diet. So you might be seeing a selection bias in that respect.
Yeah, exactly. It's like a self-selection bias that they come towards us because of those side effects. And I fully agree with you. Yeah. So maybe I'm just benefiting from, I have glasses on that allows me to, see more people who do develop these side effects over the course of time. For sure.
We all have glasses on.
Yep.
Yeah. Agreed. At least we can admit it.
Okay. and then Cyrus, what was your second question?
Okay.
And then, sorry guys, I probably have like 5 minutes. My family's begging me to go to the Super Bowl party.
Yeah, for sure.
Here's question number 2. What are the most clinically relevant methods to measure insulin resistance? And the reason I ask this is because, again, a lot of the times when you look into low carbohydrate literature and they say, oh, people ate a ketogenic diet or a low carbohydrate diet and they improved glycemia and or quote unquote reverse diabetes or went into remission, they're only using fasting insulin and fasting glucose to make that classification. They don't use any glucose challenge. There's no OGTT. There's no clamp. And therefore, they're only measuring sort of one aspect, the fasting metabolism aspect of insulin sensitivity, but not the glucose challenge aspect of insulin sensitivity. And from everything that I've learned all throughout grad school and beyond, that's only measuring, effectively half of the insulin sensitivity picture.
I think that's somewhat right. Although they love this like Kraft test, which is basically like an OGTT, and you measure. Maybe it was Ralph DeFranza that first described it. Basically, you measure the insulin response to a meal. But yeah, you're right. I mean, the gold standard is a clamp, although I have my own problems with that because it's also done in the fasted state.
It's also done in the fasted state. It's also a supraphysiological dose of insulin as well.
Well, it depends. You can control that. I mean, you can decide how much insulin you're going to use. I think what it allows you to do is determine insulin sensitivity at a tissue level, which is important because obviously, whole body insulin resistance is sort of a wastebasket that could reflect insulin resistance in any of the metabolically active tissues. But I actually think, honestly, the clinical, as bad as it is, I think clinically, the fasting insulin is, or home IR is probably as good as you're going to get without a clamp.
Yeah, it's the problem that I have with it is just incomplete though, because just like we're saying, you could eat a low carbohydrate diet, you can get to a point where you're secreting effectively zero insulin or very, very small amounts of insulin. So your fasting insulin is going to be great. Your fasting glucose is going to be great. And if you do the HOMA IR calculation just off of those two variables, you'll find out, oh, this person's very insulin sensitive.
But
and if
do you
insulin
think
sensitive is synonymous with glucose tolerant, then we have a problem, because as soon as they eat a carbohydrate rich meal, boom, glucose and insulin go through the roof.
But that's where, like, I probably disagree a little bit, because I don't understand why the hypothetical, like, I don't go out and eat glucose, so, or I don't eat a lot of it. I tolerate the glucose I eat very well. So maybe the thing to do is to look at the insulin response to whatever the meal is. I mean, it's very difficult to untangle the chicken and eggness of insulin sensitivity with I mean, my way of thinking it, and this is something like somebody like Jim Johnson would argue the other way around, but I think that improved insulin sensitivity leads to decreased fasting insulin or decreased circulating insulin, not the other way around. Jim thinks it's hyperinsulinemia leads to insulin resistance, or maybe both. But well, I think that you improve insulin sensitivity at the tissue level, and therefore the reaction is the pancreas just makes less insulin. That's my
agreed. I would agree with it.
Jim has evidence from mice, and I think Jim's belief, and Barbara Corky and a bunch of the other people believe that there is at least as much of an impact of hyperinsulinemia in causing insulin resistance as the other way around. So, and that's a long-standing debate forever and ever. I mean, there's a lot in this field that's unsettled. I mean, you can take two people who know everything in the world about hepatic insulin sensitivity and sit them down in the same room, and they'll argue about whether there's even enough impact of insulin signaling in the hepatocyte directly. And there's a whole host of literature about the relative impact of insulin on hepatic glucose output, whether it's direct or indirect. So the problem is there's no simple way to measure insulin sensitivity. And I guess if you want to define it as being sensitive, being able to tolerate carbohydrates, tolerate glucose, then that's a different thing. I would bet that if you took somebody on a very low carb diet and you did a clamp, that they would have very high relative tissue insulin sensitivity.
Okay, so I actually, I'm glad you brought that up, actually, because I don't think that would actually be true. Not to say that you're wrong, because you could absolutely be right.
So I think that this question of how to test insulin resistance really depends on the first question, which is that does it matter if you are glucose intolerant, which is basically insulin resistant? Like low carb people don't want to call it insulin resistant because they think insulin resistance is by its nature bad. It's like, I don't think we know that. In the context of diabetes, it's bad, but like generally speaking, in all contexts, is it bad? Is it bad in the context of a ketogenic diet?
Okay, so just so we have a clear answer for Cyrus. So Cyrus, you're asking, okay, what's the most definitive test? What's the best test for measuring insulin resistance? We agreed on the glucose clamp technique.
I don't think we know, because we don't know like what's important. That would what I would say.
Okay, so we did not come to agreement on the clamp.
Which goes back to my previous question of like, is it actually dangerous to be eating a very low carbohydrate diet in the long term? Third question was, what laboratory definitively determines whether a person has reverse type 2 diabetes? Is there a consensus on this? Because Virta seems to have their own classification for what reverses type 2 diabetes. But according to the American Diabetes Association, in order to be diagnosed with type 2 diabetes, one of the four following things has to be true. Number one, a fasting plasma glucose of greater than 126. Number two, a 2-hour plasma glucose level of 200 or greater on an OGTT. Number three, a random fingerstick glucose of greater than 200. Or number four, an A1C greater than 6.5. So that's basically, if any one of those four are true, then the ADA says, boom, you have type 2 diabetes. However, in order to be considered non-diabetic, not all four of those are used. Again, in the Virta situation, I'm just sort of picking them out because they presented this data recently. They're saying, okay, we're quote unquote reversing, we're putting people in remission, and they're doing it based off of an A1C value only. There's no oral glucose tolerance test. And I think that's incomplete science, right? If you are going to be diagnosed with type 2 diabetes, one of the following four must be true, right? Either A or B or C or D. In order to prove that you are not diabetic, you would have to prove that A and B and C and D are false. Is that true?
Correct. Yeah, logically that would follow because it would just be because if you have a disjunction, okay, Q or P or R or S, and then you would have to, in order to show that it's not the case, you would have to say not Q and not
Q
P and not R
P
and not correct. Yeah.
Exactly right. Exactly. So that's my whole point, right? If the American Diabetes Association is considered the ultimate, authority here on the diagnosis of type 2 diabetes, then A or B or C or D must be true in order to progress to type 2 diabetes. So in order to prove that you're non-diabetic, then A and B and C and D must all be false. But if you go into the literature and you take a look at what is actually happening, they're not measuring A and B and C and D. They literally measure either A or B, and they say, oh, look, boom, people have either dramatically improved their glycemic state, or they've reduced insulin resistance, or they're non-diabetic. And my thesis in this situation is that that's just incomplete science.
Yeah, so if it depends on what they're saying. If they're saying that the person does not have diabetes, then yes, I agree. So if someone says, okay, this is the definition for having diabetes, so Q or P or R or S, and then they say, okay, then they do. If someone wants to say they do not have diabetes, then I agree. They would have to show not Q and not P and not R and not S. But if they just want to say another claim, if they want to say, okay, I'm not saying you do not have diabetes. I'm saying you have diabetes and you have significantly improved your diabetes. They can kind of weasel out of that. There's some wiggle room there. But yes, if they want to make the claim that this patient no longer has diabetes, yes, if that is the criteria, they would have to, logically that would absolutely follow.
Okay, perfect. So, it could be that I just have a bone to pick with Berta, and I'm fairly willing to admit that. But throwing around the term diabetes reversal when you're not testing all four of these is, I think, slightly irresponsible. And we can end the conversation right there.
This is gonna go back to the conversation we had earlier. Yeah, that
like the question is where do these? I found an article that's first authored by Sarah Hallberg. She's a big Virta person. And then I found a reference in that article. Okay, so here's a sentence in that article. The terms such as partial, which is an HbA1c below 6.5 without glycemic control medications for 1 year, or complete below 5.7 without glycemic control medications for 1 year, remission, have been defined by an expert panel as more evidence accumulates that points to the possibility of avoiding the presumably progressive nature of type 2 diabetes. And then it gives us a article link, which I'm going to now post as I actually go to the article, and hopefully, and so the name of the article is How Do We Define Cure of Diabetes?
Exactly.
So reversal, no, there's no reversal in this paper. I don't know where that comes from. I don't know why Ethan says that, but these definitions in this paper that it's published in Diabetes Care, which is one of the important journals, and there appear to be a lot of, people at good universities here. I don't know. I'm not a diabetologist. I don't know who these people are, but this paper defines complete and partial remission in the same way that Virta does. So I guess the question is, these are definitions that these guys came up with. They're weird to me, and I think we all agree that they're weird, but what's the takeaway from that? I guess I would ask, what are we getting at? We don't agree, none of us do it then, right? But how do we
Well, here's the bottom line. The bottom line is, okay, if when you say diabetes is cured, do you mean to say that the patient does not have diabetes?
What does it mean to not have diabetes, though? Does that, so it's defined?
I can tell you what my definition is, but before we get into that, just I presume that when someone says they're cured of something, not just that it's remitted, but they are cured, presumably that means they don't have the disease that we're talking about. If I cure, and that's how we use it in any other context in medicine. If someone has an infection and I cure them, I treat, not that I just put the infection in remission, but I cured them of the infection. That means that, I take that to mean that the patient does not have the infection.
Okay. Yeah.
Yeah. So in this context, then what I would say is that in order to be considered, non-diabetic or reverse diabetes, your A1C should be less than 5.7 for at least a year's duration, and you should be on no oral hypoglycemic medications and no insulin. And I would throw into there that you would be able to perform, you would be able to pass an oral glucose tolerance test if administered at any moment. And that, the oral glucose tolerance test is something that you won't see in this paper. And that's something that, again, Ethan might not agree with, and the low carbohydrate community might not agree with. But I'm willing to argue that that would be a very important aspect of glucose metabolism that just isn't, it's being completely ignored by this reversal criteria.
And just so everyone understands this, like this is in logic, this is called, I believe it's called De Morgan's law. So if you have a disjunction, so P or Q, in order to say that, so the negation of that is the same thing as saying not P and Q. So you just
Correct.
take a negation, you put the negation in front of it, and then you change the conjunction to a disjunction.
Right.
So in propositional logic, that's called De Morgan's law. So if you say P or Q to say the negation of that, it's not P and not Q.
Right. Hey, so I agree with you actually, Cyrus. That makes sense. Like what you're basically saying is Birch's definition of remission, reversal, etc., and also this diabetes care article is actually incomplete because the criteria that say you don't have diabetes, the criteria that you say you do have diabetes are actually, there's actually more criteria that are not a part of the criteria of reversal.
Yeah.
So if you're going to say this is the criteria for someone, this is having condition X is defined as Y, then not having condition X is defined as not Y. And there's no way around that. So if you're going to have a criteria for diabetes cure that's not anything other than the negation of what defines diabetes as what will get you to diabetes, then I think we have a huge problem, because that just goes against propositional logic.
So think about it this way. Why would you be using an oral tolerance test to diagnose diabetes, but not to undiagnose diabetes? Right. It doesn't make any sense.
Yeah.
It literally doesn't make any sense. It's an incomplete criteria for undiagnosing diabetes.
And there's no way, and anyone who disagrees with that, you have to disagree with propositional logic.
Is that what it's called?
No, you have to disagree with propositional logic, or you have to say I accept propositional logic, but I reject De Morgan's law, or something like that, which means you are rejecting propositional logic. Yeah, it's really bad.
Okay, perfect. I mean, I literally have been thinking about this for like the better part of 6 months. This is the first time I've actually had like a discussion with very educated people about this subject. So I just wanted to make sure that I'm not sitting here going crazy, inventing my own logic, and that this actually does hold true. But I'm glad to hear you guys say that it actually does make sense.
No, it does make sense. And then to Ask Yourself Discord, it's not this Discord, but we actually have a prop logic bot which checks the validity of any arguments. So you can actually plug things in propositional logic notation and see if they come out valid or invalid.
Okay.
Yeah. But yes, this is easy to tell. Yeah. So it's easy to tell that the negation of P or Q or R or S is not P and not Q and not R and not S. Correct.
Okay. So maybe I'll just pick this up with the ADA then.
I don't know. This is really bad. Yeah. Yeah. I mean, look, I think I know what they would try to say. They would try to say, okay, yes, like as a syllogism, you'd be right, but like it's not practical to take a patient and put them through all of these tests. But that doesn't change the fact that you still have to call it something else.
Why is it practical to put them through the test of like any of these tests to diagnose them, but it's not practical?
It is practical. Because the reason it is practical is because it's an or there. It's a disjunction. Not a
I get you, but no, but maybe that makes sense then, because in practice, actually, you're only going to use one of those.
Yeah, you're only going to use one, and that's why they're going to say it's practical. But they're going to say, if I have to use all four, then it's going to be impractical. I get that, and I understand that it's impractical. However, that doesn't mean you get to break propositional logic. You just have to call it something else. Don't call it that you've cured diabetes. Call it that you've. I'm okay with saying you're putting the diabetes in remission. You're improving the situation. That's fine. I'm not okay with saying you're curing it. I'm not okay with saying that the patient does not have diabetes.
Well, how about this? If you get one of those criteria met,
the other option is you could redefine what makes someone have diabetes.
Right.
If you redefine that criteria, you can get around it as well. But if you want to stick with someone has diabetes if and only if they have P or Q or R or S, then someone will not have diabetes if and only if they do not have P and do not have Q and do not have R and do not have S.
Exactly right.
Yes.
You hit it on the head. So it's kind of like, it kind of brings us full circle if you think about it, because
You could also define remission or reverse. You could say if they have one of these and little reason to suspect that the other ones are not the case. So if they have fasting glucose below 126, and we believe that there's no reason to suspect that their OGTT is going to be bad, blah, 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 then we can call that, for all practical purposes, remission or reversal. You can have a practical definition. Does that work?
The term reversal is pretty cringy. People like to associate reversal with cure. That's the only problem. That's the only hesitation I would have on that. And we wouldn't call that a cure, right?
What do you mean, like we wouldn't call that a cure? So, like, let's say you get diagnosed as having diabetes based on fasting blood glucose of like 170 or something. You're just really diabetic, and then you reduce your fasting blood glucose below, you get it to 80. And then the way to account for those other criteria, you could say, if there's no reason to suspect that those other criteria are still going to be met, then for all practical purposes, you can consider that.
I don't buy that. No, I'm sorry.
I can't. Because when you diagnose somebody with diabetes, right, you're not gonna apply all of those tests until something hits. You're only gonna apply whatever.
If you did, by the way, if you did apply all those tests until something hit, they would have diabetes if one thing hit. That's just how it's defined. Even if no one does that, that's tangential if no one does that. The point is, if you're defining diabetes as that way, that's how it's going to happen. That's how it, I mean, not how it's going to happen, but that's how it is defined to be. If someone were to do that, if they were to get those tests, they're diabetic if only one of them hit.
I just feel like defining things in terms of this sort of logical consistency, that strict logical consistency, which for all practical purposes, most people would agree that the disease is not present anymore, but not being able to say that because the reversal criteria don't perfectly match the diagnosis criteria, it just seems strange to me.
Here's what you can say. You can say, if it's a reasonable assumption to make, that all the other things would have shown up negative, then it would be a reasonable assumption to make that, okay, maybe this patient doesn't have diabetes, because we would assume, if predicated on hinging on the assumption that these other three tests would be negative too. You can say that, right, as long as you make it but you have to keep it as an implication. I would not say the patient does not have diabetes. I wouldn't take it off their chart.
Well, okay, but for the same thing, let's say you take somebody's fasting blood glucose and they have a fasting glucose of 100, and you say, well, for all intents and purposes, this person probably doesn't have diabetes. Yeah, that's what we actually are saying, right? Because we're not actually applying those other tests.
Also isn't how it's done. It's not how it's done in practice at all. In practice, when someone gets diagnosed with diabetes, that almost always stays on their chart, on their history. It's and it's going to be stamped and engraved. It's going to take a lot to get that diagnosis off, and that is how medicine is done. We don't just we did one test and they don't have it. They controlled it all, and then we take the diagnosis of diabetes off their chart. No, I don't know any primary care doctor who does that.
Fair enough. Yeah, fair enough. That's a good point.
But if they did get to that, someone did show, okay, a patient says, okay, guess what? I did all 4 of these tests and they're all negative. They're consistently all negative. Then I would suggest, then I would say, okay, the diabetes ended. And you would make a case for okay, maybe we can take it off their chart.
Mm-hmm.
But that's why it's so rare for diabetes to ever come off someone's chart.
Yeah, and I think one of the methodological flaws here is that if they're not performing all 4 tests on individuals, but yet claiming a diabetes reversal, it's just incorrect. Sure. It's just incomplete.
Sure.
So then the terms partial remission, partial remission come into play, where now you have these it's fuzzy. It's not black or white. It's not either you have diabetes or you don't have diabetes. It's okay, you're migrating towards a non-diabetic state, but yet you still have slightly elevated blood glucose. You might be still using oral diabetes medications. So I think having this spectrum, I think, is totally valid. But again, if you're not using all 4 tests, if you're using 4 tests as diagnostic criteria but not undiagnostic criteria, that's just bad science.
More specifically, if you use 4 tests as a disjunction to confirm something and not using the conjunction of those 4 tests to disconfirm something, then it's bad science. It's bad logic.
I got to write that one down. You're way smarter than me.
Yeah. If you're using 4 tests as a disjunction to confirm a proposition, and then in order to be consistent, you would have to use the same 4 tests as a conjunction to negate, more specifically, the negation, the opposite result of those 4 tests as a conjunction to negate that same proposition.
Okay, got it. I would agree. Fully agree.
Yeah. That's how you want to put it. The other way of saying it, if you want to just quickly look it up, is just write down De Morgan's law.
De Morgan.
Yeah, that's how you want to phrase it to the ADA. Yeah, exactly. All right, I think we agree on that question.
The last thing I would want to say here is that it kind of brings everything full circle, and I've never verbalized this in this manner, but maybe let me try it right now. If you define diabetes, there's a cause, and then there's symptomology. If you define the cause of diabetes, like the first domino in the chain to be glucose intolerance at the level of the liver and or muscle, that then leads to a collection of symptoms, including high blood glucose and high insulin, then what that would mean is that in order to reverse diabetes, you would have to reverse the symptomology and the underlying biological phenomenon that caused it in the first place. Or in other words, you'd have to reverse the glucose intolerance as well. So if the glucose intolerance causes hyperglycemia and causes hyperinsulinemia, then in order to reverse diabetes, you'd have to get rid of hyperinsulinemia, you'd have to get rid of hyperglycemia, and you'd have to become glucose intolerant. But yet what I think the low carbohydrate community is doing, and what I think a lot of the research in the low carbohydrate community is doing, is saying, look, we no longer have the symptoms. Glycemia is normal. Insulinemia is normal, but they never go to the root cause and measure or even try and reverse the glucose intolerance that was the originating cause of the entire disease process.
I get you, and this relates to the third point that we were making, which is that on the OGTT, that criterion also needs to be fulfilled to talk about remission or reversal. And since they're not talking about that, we're not only talking about like A1C and glycemia, then they're not actually fulfilling what should be required in order to have true reversal according to the diagnostic, the original diagnostic criteria. So I agree with that.
Yeah, so it's in other words, by eating a low carbohydrate diet and living in a glucose state, you're going to have normal blood glucose, and you're going to have normal insulin, which is fantastic. But you're not fundamentally changing the biology of your liver and muscle to become more glucose tolerant.
I'm not sure that that's the case, though. That's the one thing I tried to talk about at the beginning. I'm not sure that it's the case that if you're able to bring your glycemia down to normal levels, that assuming you have an intact pancreas, my assumption is that people who are able to become euglycemic, if they got carbohydrate again, they would be able to tolerate it I do believe that they are reversing the underlying pathology. And that's actually in contrast to what I wrote earlier, because it's just kind of what I'm learning about carbohydrate restricted diets. I'm not actually sure that carbohydrate restriction reduces glycemia isocalorically. I don't actually know if that's the case anymore, just because of some people who are doing work on this who I respect a lot. If you don't lose weight, and I think losing weight is what's going to be reversing the underlying pathology in terms of the fat in the muscle, fat in the liver, fat in the pancreas. So I believe that is being reversed whenever they're losing the weight. And so I believe that if they did actually try these tests, many of them would actually, who have good glycemia, would actually see the underlying pathology reversed. But they never test this. They never actually test whether this is reversed. But my assumption is that it is reversed. So that's all I would say.
Okay, so here's what you guys could do to help me out. Actually, is that I've done what I consider to be relatively thorough search in the literature to try and get some data here for what happens to people who eat a low carbohydrate diet first and then are challenged with an oral glucose tolerance test or a clamp. Do they demonstrate significantly decreased insulin sensitivity? I know it to be true empirically. There's plenty of studies that actually show that after a single high-fat meal, people with type 1 diabetes, that their insulin requirements increase by 65% in the subsequent 12 hours. But What I'm looking for is some study or some collection of studies that basically says this group of people went on a low carbohydrate diet, and then we put them through a clamp, or then we put them through an OGTT, and here's how they fared versus their, the control group.
Yeah, I think that data exists. I'll try to find it.
Okay. Yeah, help me out with that, because I think there's a lot to be learned in that data. And, it can lead us to sort of understand a little bit more clearly that if you just choose to avoid the symptoms of diabetes, which is high glucose and high insulin, but yet you're still living with glucose intolerance, to me, that's not good enough. To me, the risk of the symptomology that is created as a result of living in a glucose intolerance, you're at a high risk for many symptoms like we talked about. Again, I don't have data to support this, so I can't point to a collection of studies that shows this, but that is what my observation has been. And that's why I think that I would like a little bit more clarity, and hopefully I'm not coming out of left field here on this.
Yeah, we would need data to substantiate that.
For sure.
It was great having you guys. Great talking to all of you, and it's great to have conversations like this, I have to say.
Yeah, thanks, man. I appreciate it.
Great. Yeah. Thanks, everybody.
Thank you, and thanks,
Avi.
guys.
Yes.
Thanks, everyone.
And I hope you enjoyed that discussion between the three of us and found that as interesting as we did. If you would like to support this podcast, please give us a review on iTunes. Share it on social media. If you tweet about it and tag me, and I am at Kevin Bass with 2 N's, Kevin in Bass, so Kevin in Bass. If you tag me in a tweet about this podcast, I will retweet you, and do it on Instagram, do it on Twitter. Those would all be great. And if you have any comments or suggestions about how to make things better, you could also send me a message, either a direct message or a tweet over Twitter, and let me know how you think about it and how you would have things be done better, or what you would like to see more of. That would all be great. I hope you enjoyed listening to the podcast.